we are very pleased to be here with us and to share your widest knowledge about exercise and sports. We thank Dr. Franchella and his foundation who has the opportunity to give us this lecture for us. So we have a group of young people who work with us. I told you a little weeks ago that we principally did in the first times images, but then we went to dedicated to clinical cardiology and especially to sport and exercise. And I said there is a lot of people who make sport here in Argentina, and principally running people. We have one medical doctor, Eduardo, who is practice of running, and he's an Ironman, and he's an important runner. And Dr. Meadows used to be also very important exercise, but now she's a mother and she's quiet. But wow. So we appreciate very much you to be here with us, and we are going to let Dr. Franchella to introduce you for us.
Dr. Thompson is co-director of Heart for Healthcare Cardiovascular Institute. I knew him when he was the president of the American College of Sport Medicine 20 years ago, I think. He has more than 400 papers. He had participated in several books, and I think that he also has the academical cardiology and preventive cardiology prize. But the best of all is that when I knew him, something changed in my life. I told him that I have, from that very moment, a great admiration of his skills to be a speaker, but also I have the pleasure to become his friend. And now we have here the opportunity to have him in Argentina because he is willing to help us, to visit us. This is the third time we have him in Argentina, but this is the first time in this style, and I think this is not the last for him, of course. And we will be at the Argentine Society of Cardiology and a meeting of Hospital de Clínicas. So I think this is a very great opportunity for us. All of us will learn today, and we will hear him, and we will have the opportunity to ask many questions about the management of cholesterol especially. And I am really appreciate the effort that Paul has done to come here. He arrived 4 a.m. and he's here now giving the lecture, and he will be for a week. So I also am very grateful to Osvaldo Mazzoli and all the teams, the partners, and Marcela, who's not in this moment, but I feel like in home.
I'm not going to talk so much about sports medicine tonight, just a couple things about sports medicine in this lecture. But what I am going to talk to you about is some questions that people ask me about managing cholesterol. And since they've asked me these over the years, I've kind of put them into a little. So this is a common question I get. What can patients do to lower their LDL cholesterol without drugs? And what I always tell them is this: you can pick you parents. Because most of your cholesterol levels, not talking about triglycerides, are really determined by genetic factors. Now you can influence it. You can follow an extremely low saturated fat diet. Really avoid the milk and meat of animals, and that will help. But you know, you only get, even with good diets, about an 8 to 10% cholesterol reduction, where you get much more with drugs. You can become a vegan. So a vegan doesn't eat any animal products at all. No eggs, no milk, no nothing. They can get somewhere about a 15% reduction, but drugs are still better. You can become a vegetarian if they don't want to do that. And I try to encourage patients to do that. Or you can become a fish-eating vegetarian. In other words, you work up the food chain. But quite frankly, nothing works as well as the medicines. What about weight loss? Won't my LDL cholesterol get better when I lose weight? And the answer, they don't want to hear. Weight loss works for LDL, but only during caloric restriction. When you're losing weight, your LDL goes down. But when you reach a new steady weight, the LDL returns pretty much to baseline, the LDL cholesterol. Why? Primarily determined by genetics, a little bit by diet. Now, weight loss does lower triglycerides, probably by increasing insulin sensitivity. And what I want to try to convince you is that when you see a patient with high triglycerides, you have to worry about their insulin sensitivity. I'm a drug addict, but I only use prescription drugs. And I'm a drug addict because they work the best in getting patients' cholesterol levels down. Now, so many patients say to me, oh, I don't want to do it with drugs, that's cheating. Quite frankly, your arteries don't care. And so I've become, over the years, I try to get people to follow diets. Some people can, but quite frankly, I go to the drugs often and early. So, what basic lipid physiology do I need to know to become an expert? So what's an expert? An expert is a jerk from out of town with slides. Right? But I always say it's not me, and I know it's not me because I got PowerPoint. Okay. So what do you need to know to be a lipid expert? And quite frankly, it's all on the next slide. So, this is the liver. I always have to remind cardiologists that there's something below the diaphragm, and it's the liver. And primarily free fatty acids, but any energy source, glucose, any energy source, provided to the liver gets made into acetyl-CoA. And it gets worked on by 3-hydroxy, 3-methyl-glutyryl-CoA reductase and made into cholesterol. The cholesterol is then esterified by this enzyme, ACAT, and packaged with triglycerides into VLDL. Now, why is it very low dense? It's very low dense because it floats. Why does it float? Because it's loaded with fat. So the VLDL particle is sent out to the capillary and it's worked on by this enzyme, LPL, lipoprotein lipase. And what lipoprotein lipase does is it takes the fat, the free fatty acids, out of the particle. So the very light particle now becomes simply low dense. It's no longer very low dense because it doesn't float as well and it's lost triglycerides. The LDL particle can be picked up by this high affinity, the high affinity uptake. This is the LDL receptor. 90% of your LDL receptors in the body are on the liver. And if you take it up by the LDL receptor, that's good. But if you overwhelm the LDL receptor, it's picked up by this low affinity uptake in the artery. And that's the start of atherosclerosis. Now, to be an expert, you have to know some of this stuff down here. So let me talk to you about that. Cholesterol is made into bile, and bile acids and bile salts, and secreted into the gut, but not wasted. It's reabsorbed. The bile comes back, the cholesterol comes back, and bile actually shuts down the production of cholesterol. You're losing a lot of bile, and we'll come back to that. You don't shut down the production of cholesterol. So bile is actually an HMG-CoA reductase inhibitor. And bile also shuts down the production of triglycerides. Now, cholesterol is reabsorbed, and that's how some of the drugs like Zetia work, right? Because they block the reabsorption of cholesterol. So what happens? When you block the production of cholesterol by blocking HMG-CoA reductase, the way the LDL actually goes down is by upregulating the LDL receptor. it's not simply the reduction in production. You gotta upregulate the LDL receptor. When you block absorption with ezetimibe, the thing that has to happen is you've got to increase the LDL receptor. Okay, we'll come back to that. So, people always say to me, do I need to take my statin at night? Now, you know, you produce most of your cholesterol at night. Why? Because, at least in the United States, the only time we even come close to fasting is overnight. So overnight, if you're fasting, you break down fat. The fat goes to the liver, and this whole process starts. So you make most of your cholesterol when you're fasting overnight. So the short half-life drugs, work slightly better at night. So these are lovastatin, pravastatin, simvastatin, fluvastatin. They're all short-acting. So you do get a better effect if you take them at night. And that's because of what we just talked about. The free fatty acids breaking down when you're fasting and coming to the liver. But the longer half-life drugs like rosuvastatin, atorvastatin, pitavastatin, they're largely unaffected. Now this is important because a lot of people have trouble remembering to take their drugs at night. And so and most of us use rosuvastatin, atorvastatin, these longer acting drugs. So you can tell a patient that they can take them anytime during the day. Just take it. It doesn't work that well in the bottle. Remember that the LDL receptor is king. You can't get by saying that in the United States. Or the queen, depending on who you think has the power. And I'm married. I've been married for 49 years, so I know who has the power. So when you use a statin, an HMG-CoA reductase inhibitor, and you block the synthesis of cholesterol, the thing that happens is you increase the LDL uptake. So I explain it to patients as follows. This is the way I actually tell patients. I say, look, I'm your liver, right? And from mom, I get the gene for one LDL cholesterol receptor. From dad, I get the gene for one LDL cholesterol receptor. As LDL cholesterol goes by, the receptors grab it, pull it into the liver, and two good things happen. Number one, the LDL cholesterol in the blood is lower because it's been brought into the liver. But number two is the liver says, I've got enough cholesterol. I'm going to stop working. I'm going to stop making cholesterol. Now, if you pick the wrong parents and you only have one gene working here, it can't pull as much cholesterol in, so the cholesterol level in the blood stays high, but the liver keeps producing, right? So having the wrong gene really affects you a lot. Now, the LDL receptor is recyclable. What do I mean by that? The LDL receptor grabs LDL. Let me stop for a minute. So how can two children, both of whom got the same defect, how can they have markedly different cholesterol levels? Well, you know, every time the cell divides, one cell will get the good gene and one cell will get the bad gene. So just by chance, you'll see some people with the same genes in the same family, and their cholesterol levels can be quite different, So the LDL receptor, I always say the LDL receptor is green, meaning it's recyclable. But I said that to the medical students once, and they thought it was really green. So I don't say that anymore. But the LDL receptor goes into the liver, it drops off the LDL, and it goes back and gets it again. 150 times. The average LDL receptor goes around 150 times, unless it's bound on the surface of the liver by PCSK9. Now, PCSK9 grabs the LDL receptor, and when it goes into the liver, the whole thing is broken down, and that's shown here. So here's the LDL particle, here's the LDL receptor. The LDL receptor has been made, and it goes to the surface, it's binding LDL, it goes into this vesicle, and then the LDL receptor goes back to the surface 150 times. Unless it's bound by PCSK9. If PCSK9 binds this on the surface of the liver, then it goes in and the whole thing gets broken down. So I know you do not have these drugs in Argentina, but they're very expensive. We now have 2 antibodies against PCSK9 that patients inject themselves with every 2 weeks. And I'll show you in a minute, they produce gigantic reductions in LDL cholesterol. Gigantic reductions. Okay, so what conditions mimic a primary problem with LDL, with lipid metabolism? Well, for LDL, hypothyroidism, nephrotic syndrome, and some drugs. This is very important, and we'll come back to it, hypothyroidism. Now, with the nephrotic syndrome, what happens is you lose protein in the urine. The liver gets the message, make more protein. So it makes more ApoB, apolipoprotein B. And when it makes more apolipoprotein B, generally that results in more triglycerides. But a lot of people can make those VLDL into LDL like we talked about. Okay, we'll come back to that. For triglycerides, diabetes is the key factor. Why? Insulin pushes fat into the fat cell. When you start a patient on insulin, they get fatter. When you start somebody on a sulfonylurea, which increases insulin levels, they get fatter. So diabetes is a big factor. Oral estrogen. Now, why did I say oral? Because when you take an estrogen by mouth, it goes into the portal circulation and right to the liver. Much bigger effects on triglycerides than if you give an estrogen patch or if you give vaginal estrogen. So you don't reabsorb those bile salts. The liver does not get suppressed and it makes more triglycerides. Saw just recently a boy who had been in an auto accident and had to have his terminal ileum removed. He was sent to me with high triglycerides. They were about 10 millimole. Right? And for HDL, oral anabolic steroids. Why oral anabolic steroids? Because if you take it by mouth, just like estrogen, it goes to the liver. And I'll show you that in a minute. Now, I apologize. These are in milligrams per deciliter. But to change it to millimole, divide by about 40. You want to be exact, 38.86. Let's do 40. But here's a woman that way back in 1988 had an LDL there. And then in 1991 it was there. And now look at it. That's a very high LDL. Divided by 40, it's 6.5 or so millimole. So what went on? Her normal TSH should be 5 or under, 4 or under. Her TSH was remarkably elevated. She was fine. She was the business manager of her husband's business. Couldn't tell she was hypothyroid. So the rule is, there's a thyroid responsive unit in the LDL receptor gene. You can't make LDL receptors if you're hypothyroid. You know, years ago, they used to measure cholesterol levels to try to decide if you were hypothyroid, right? Because you can't make LDL, and if you can't make LDL receptors, you look like you picked the wrong parents. Hypothyroidism causes an acquired LDL receptor defect And I always say, every patient with any lipid disorder is hypothyroid until you prove it otherwise. I took care of a surgeon, very busy surgeon. He had problems with his cholesterol. I'm giving him the prescriptions in the hallway. It's not working. Finally I said, Steve, you gotta come to the office. So the first thing my nurse does before they'll see me is she gets a TSH. He was markedly hypothyroid, right? And that's why the drugs weren't working. Remember, the bile acids come back and suppress the production. But also remember the free fatty acids here. Insulin keeps fat from breaking down. Insulin makes you fatter. And what a lot of people don't realize, it takes more insulin to regulate fat than it does to regulate glucose. Triglycerides are an early warning sign of diabetes. Nobody taught me that in medical school. But over the 45 years, I've seen all these people with high triglycerides who 5, 6, 7 years later have high glucose levels. Free fatty acids is the key. Every hypertriglyceridemic patient is a diabetic want to be. They're all want to be diabetics. Now, they're not all. They're not all. But at least think about it. It takes more insulin to regulate fat metabolism than it does glucose metabolism. And here's a study we did years ago looking at the effects of testosterone, injected testosterone versus oral stenozolol, the Ben Johnson drug from the 1988 Seoul Olympics, which I happened to be at because at that time I worked for NBC as a commentator. So this is the Ben Johnson drug, and we published this in JAMA in 1989, just after the Ben Johnson episode. Here are a bunch of men that we gave stenozolol to, and this is their HDL, and this is in millimole. And here's the testosterone. Testosterone didn't do very much to HDL, but within 1 week, the HDL had plummeted with the oral drug. The same thing with estrogen. You take it by mouth, portal circulation, liver, effects on lipid metabolism. Now, why is this important? Because many over-the-counter fitness products have anabolic steroids in them. The kids won't buy the product if they don't see results. So in the United States, the companies put anabolic steroids into the fitness products. The kids get bigger, they tell their friends, this worked. I get these kids sent to me because they have HDLs, which are less than a millimole, a mole, less than a mole. So who should be treated for increased lipids? In the US, just about every American. Now why? Why just about every American? Because about 40% of Americans die from heart disease. Atherosclerotic cardiovascular disease, atherosclerosis. And we need to let something else kill us. At least in my opinion, I'm a cardiologist. And also, a little treatment goes a long way. What do you mean a little treatment goes a long way? What does that mean? What do you mean? Well, this is called the legacy effect. And so I want to talk to you about it and how I use it with patients. So this is the West of Scotland study. Now you all remember the West of Scotland study, but this is a study that looked at the long-term safety and the effect of lowering LDL cholesterol 20 years later, a 20-year follow-up. So these were men who had no prior MI, and they were followed up for 18 to 18.3 years. The percent who were using statins, this is the pravastatin group. They got treated with pravastatin during the study. These folks got placebo, and this is the year. So 1 year after the study was over, 6 years after the beginning of the study, but 1 year after it was over, you can see that about a third were on pravastatin and about a third were on placebo. 3 years after the end, You can see it again about a third, a little higher, a little higher. And then here we are out at 10 years, about 38% in the pravastatin group, 35% in the placebo group. But what happened to those people? Well, first of all, if you look at the deaths over 20 years, if you look at all deaths, here's placebo, here's pravastatin. So what's pretty clear is the pravastatin isn't killing them, right? There's no bad effect. But if you look over here at cardiovascular deaths, you can see that the pravastatin has continued to make them better, even though almost the same number of people are treated. Now look, here's the events over 20 years. Pravastatin, all cardiovascular events, cardiovascular disease events, look at how wide those are. Non-cardiovascular disease and coronary heart disease. So what this looks like to me is the difference is getting bigger over time, even though 70%, 60 to 70% are not being treated. So I use my arms and I show to patients, I say, look, here's this study, here's 5 years, here's the placebo, here's the pravastatin, but if you follow those people out, they seem to divert. So I'll tell you in a minute how I use that clinically. It's not the only study that showed that. This is from way back in 1986. It's the 15-year mortality in the coronary drug project. People in the coronary drug project were treated with estrogen, didn't work. Thyroid killed a lot of people, right? But all these things lowered LDL. And niacin. And what happened with niacin is that there was no difference at the end of the study. But when you looked at these people out at 15 years, there was a significant reduction. The point is, treating people for a period of time makes their arteries younger. So how do I use it clinically? I say to patients, let's just treat you for 5 years. Okay? A lot of patients don't want to be treated at all. So I say to them, let's just try it. Let's see. Here's this study. Here's the placebo. Here's the pravastatin. So let's just do 5 years. And what happens is they find that the drugs don't bother them that much. Now, on the other hand, I have some people who really cannot take statins because they get muscle trouble. And they're crazy worried because they can't take the statin. And I say to them, don't worry about not tolerating the medicines. The legacy effect is going to get you benefit even when you're not on the drug. Now, true, I would prefer they were on the drug, right? But they do get some benefit even from relatively short treatment. So what do the guidelines say? I know you do guidelines. I am not a big fan of the guidelines, and I'll show you why in a minute. But let me do this. I want to make sure I keep an eye on time, because I know I'm speaking slowly, and I don't want to go long. So it depends on the guidelines. Here are the guidelines we're presently using, produced in 2013. And basically what they say in these guidelines is a couple of things. One is that you should recalculate people's risk. So you can calculate their risk, and then you recalculate their risk every 4 to 6 years. But the group that should be treated is those who have heart disease. And they get either high intensity or moderate intensity statins. And I want to come back to this in a minute. Those with LDLs greater than 190 milligrams per deciliter, or just under 5 millimole, they get high intensity statins. Or those who have diabetes, they get moderate intensity statins. Or those who you estimate their risk and it's greater than 7.5%. 10-year risk. 10-year risk. And what do they get? Everybody gets moderate to high dose statins. Now why do they get that? That's what was studied in the studies, and the guidelines have to depend on studies that have outcome data, right? Oh, I'm sorry. And then there are other things you can use to estimate risk, such as genetic hyperlipidemia, family history, a high CRP greater than 2, or a calcium score, which we'll come back to in a minute, but a high calcium score. And you know that when you put down atherosclerosis, you also put down calcium, so a high calcium score. An ankle brachial index less than 9, and an elevated lifetime risk. I think this is very important. This is how you estimate the 10-year risk. You can get this calculator. I use it all the time in the office. But 10 years is nothing. So I'm 71, right? I don't want to just make it to 81. Plus, I got all these grandchildren to put through college, right? I got 7. So 10 years is nothing. Think about that. If you told somebody that was 40 that, hey, here's the good news, you don't have any risk for the next 10 years, or your risk is low for the next 10 years. Now, I grant you, no one gets out alive, right? We all die. But 10 years is nothing. So I either calculate lifetime risk or I estimate it. So how do you estimate it? Suppose somebody's 40. I calculate their risk at 40. Then I recalculate them with them being 50, and I add the 2 together. Now I got a 20-year risk. And then I make them 60, and I add the 3 together. Something like that. You can estimate it. The calcium score greater than 75 percentile for age, sex, and ethnicity. We find calcium scores to be very useful. Now remember, there are no treatment goals in these guidelines because randomized controlled trials did not test goals. And these, I think these are historical recommendations. I don't think they're any longer pertinent because there's new evidence that really the lowest possible LDL is really the best. The lowest possible, and what is that? Okay, we'll come back to that in a minute. Hold on. Okay. Now there are other goals, so I'll show you some of those goals. Here's the National Lipid Association. They want basically everybody under 130 or less than 100, or if you're high risk, less than 70 milligrams per deciliter. Remember, divide this by 38 or about 40. And that's 3.35 right here. And down here, for that, is a millimole of 1.8. So there are goals available, but the idea is you want just about everybody under 3.35. But I don't think they're aggressive enough. I don't think they're aggressive enough, and let me show you why. So here's the 4-year trial. Now this is a PCSK9 inhibitor, evolocumab, and clinical outcomes in patients with cardiovascular disease. This was a high-risk group of patients, high risk. They had diabetes and heart disease. They smoked and had heart disease. They were high risk. And really, it's a proof of concept. It shows you that lower is better. That's the proof of concept, that even lower is better. And here's the study. So here's where the placebo group was. Their LDLs were about 2.25 millimole. 90 milligrams per deciliter. And they drove them all the way down to less than 1 millimole. And they did that quickly with this PCSK9 inhibitor, evolocumab. What happened to the patients? Oh, but look at how low that was. That's incredibly low. What happened to the patients? Well, over 36 months, there was a 2% absolute reduction in events. 2%. Basically telling you that what we ought to be trying to do is get people lower. These were high-risk folks, so they don't apply to everybody. But the principle is there, lower is better. Next thing people ask me is, can an HDL be too high? And the answer is probably, because cholesterol may get stuck in the HDL and not get to the liver. So suppose you're a garbage truck driver, right? Your garbage truck for the body is HDL cholesterol. If you got the garbage truck full, but you're just driving around Buenos Aires, that doesn't do anybody any good, right? You gotta go to the dump. And what it looks like is that as your HDL goes up, things get, if this is your risk of heart disease, things get good, better, until you reach an HDL of about 80 or about 2 millimole, and then the risk actually starts to go up. So that very high HDLs may not be productive and may actually turn out to be worrisome. That's early, but that data is coming. Do I need to order particle sizes, lipoprotein profiles? Do I need fancy tests? I don't think so. You know, if you want to know how many particles your patient has in the blood, if you want to know how many particles, every bad particle has one ApoB. How many ApoBs on a VLDL particle? 1. How many ApoBs on an LDL particle? 1. How many ApoBs on a chylomicron? 1. Get the point? How many ApoBs on an HDL? None. So if you want to know how many particles you have, simply measure ApoB. It's a cheap way to estimate particle number. Now what else? Coronary artery calcification scores if you can do it. But if you see coronary artery calcification in someone, it makes you worried. If you have a 0 value, you basically have no risk. Now the other thing I'm very interested in, and you're seeing this more and more, is lipoprotein A. Lipoprotein A is a type of LDL cholesterol which takes any cholesterol level you have and makes it worse. A 0 coronary calcification score is an almost guaranteed ticket to ride, as the Beatles would say, for 10 years. Basically, you're not going to have anything happen. Not a guarantee, but close. I'm going to skip this, but this is just to point out that statins actually increase coronary calcification. Statins increase coronary calcification. I'm going to skip the data, and this is probably what happens. No statin therapy, the atherosclerosis progresses. Statin therapy, the atherosclerosis kind of congeals and solidifies. There's evidence now that very, very high calcification scores may be somewhat protective because they make the plaque stable. More to come on that, but statins do increase calcification. So how do you treat a high Lp(a)? Thyroid lowers it. Androgens lower it, but we don't recommend it. Estrogens lower it, we don't recommend it. Niacin lowers it. These new drugs, the PCSK9s, lower it. But what I do is I treat the risk, not the risk factor. So if the lipoprotein A is high, I push the statins or push the ezetimibe higher. So we're more aggressive about the LDL lowering. You get why. You want to treat the risk, not the risk factor. Believe it or not, the best thing you can do for someone with hypertension is lower their cholesterol level. Forget about the hypertension. Lower their cholesterol level. Can I make the narrowing in my arteries go away? Yes, you can. Best study was probably this one in Jack back in 2011. Magnetic resonance imaging of carotid plaque during lipid-lowering therapy. 84 subjects, 33 that could be measured. 3 years of intense lipid therapy with statins, niacins, sequestrants. And here's what happened. So here's year 1. You treat the person and their plaque regresses and then it kind of flattens out after 2 years. Comes down, kind of flattens out. This is shown here. So here's a lot of plaque in the carotid, and after 3 years, a lot less plaque. A lot less plaque. Here's another patient. A lot of plaque at baseline, and you can see it's almost gone. You get the most regression in the first 2 years. One of my students did a review of the time course of regression, a lot of articles. 31 showed regression, and it took an average of about just under 2 years. So high treatment, aggressive treatment for a couple of years, and you can get regression. The more LDL reduction you got, 40%, the better off they were. Regression increased with the percent LDL reduction and the intensity of the statin treatment. So what about statin side effects? And then I think I'm going to quit because I want to make sure you have time for questions. This is our paper on statin-associated side effects. Let me see, it was published 2 years ago. Well, I'll tell you, time flies. You publish these things and you think you're done, and they're old very quickly. And then this is a review that we did, What to Believe and Do About Statin-Associated Adverse Effects, again in 2016 in JAMA. So here are the list of potential side effects. Statin-associated muscle symptoms, including statin-induced necrotizing autoimmune myopathy. I want to talk about this just for a minute. It's now clear in very, very, very few patients that statins can make you form an antibody against HMG-CoA reductase. Maybe because the statin sensitizes you to your own enzyme. But it's important to know this. These are people who present with muscle weakness and high CKs, right? And you stop the statin and they do not get better. If they don't get better, when you stop the statin in someone with muscle symptoms, they should get better in a week or two. They should start to get better. If they don't get better, you need to think about this, because they can go on to wind up in a wheelchair. Very few patients. Just this week, last week, in JAMA Internal Medicine was a report from Australia. I wrote the commentary on it, talking about how that this is much more common than we thought about. So somebody who's sick and it doesn't go away. We call these statin-associated muscle symptoms because they're just associated with drugs, but diabetes goes up with statins. Sleep, depression is rheumatoid. Elevated liver function test, decreased renal function, tendon rupture, hemorrhagic stroke, interstitial lung disease, and lower testosterone levels. Now let me dismiss these. Liver function tests go up a lot, but don't mean anything. Don't mean anything. They go up in the first 12 weeks. Decreased renal function doesn't really happen. Doesn't really happen. Lung disease, there is good evidence that it may be related, but not enough cases, so it's very rare. And believe it or not, average testosterone level does decrease slightly. Nobody likes to talk about it. The average is very small, but some people will get large reductions, right? The average isn't everybody, but on average it goes down. ALT often goes up in the first 3 months. I put up with it as long as it's less than 3 times baseline. So if someone starts out with a high baseline, I let them get to 3 times of it. What do you do about increased CKs? Well, first of all, is it exercise related? Here's a study we did way back in 1997. 60 men, double blind, randomly assigned to lovastatin 40, a placebo. Right here we had them walk downhill on a treadmill for 45 minutes. You can see that if you walk downhill, you injure your muscle. At 24 hours you had a doubling of your CK. But if you walk downhill on a statin, you get much bigger muscle injury. So the combination of exercise and statins produces big CKs. So if the CK went up, I simply asked, did you do exercise recently? So is it exercise related? If it's less than 5 times the upper limits of normal, I ignore it. 5 to 10 times, I monitor it. If it's more than 10 times, you got to consider stopping, even if there's no symptoms. Do statins cause diabetes? Yes, but it's a very low. And it came out of the Jupiter trial. Because of time, I'm going to skip this. The point is this: you had to have risk factors. If you had risk factors to develop diabetes, you got it. Now remember, this was only a 2-year study. So I think long-term, statins will increase the risk of diabetes, but they reduce cardiovascular events. Big reduction in cardiovascular events, a lot less cardiovascular events, and a few or more diabetics. But I do think this is related. And how do you diagnose SAMS? It's very difficult to diagnose it. You know what? I think I'm going to just jump through this. And so how do you take care of it? I ask the patient, can you put up with this? If they can put up with it, I just measure the CK to make sure it's not bad, and I try to keep them on the statin. Or if they can't, I stop the drug till there are no symptoms. Symptoms are gone. Then we try another statin, or we try Zetia alone, ezetimibe alone, or lower doses, plus or minus ezetimibe, another class of drugs. Chinese red rice yeast. You know, there's a lot of statin in foods. You know those umbrella mushrooms, the umbrella mushrooms? They're loaded with statin, believe it or not. So, and Chinese red rice yeast has a lot of statin in it. And I have a lot of patients that will take anything as long as it's not a prescription. Right? They'll do anything, but they won't take what I give them from a prescription. You can use atorvastatin, rosuvastatin, pitavastatin, long-acting statins every other day. Here's a study we did way back in 2008. We gave people Rasuva 5 or 10 twice a week, Monday and Thursday. Most of the people were on only 5. 26% reduction in LDL. Then if you add Zetia, ezetimibe to that, and you get another 20% reduction, you've got almost a 50% reduction with very low chance of side effects. You get the greatest percent reduction per milligram of drug at the lowest statin doses. Very low statin doses do a lot. Every time you double the dose, you only get a 6% additional reduction. So if you put me on pravastatin 20, I'll get about a 25% reduction in my LDL. If you double it, I don't get another big reduction. I only get another 6%. You also get the fewest side effects, and some LDL reduction is probably better than none. So after that, I do what's called pulse therapy. In other words, some people will get pain after 3 months. I'll treat them for 2 months. Give them a month off. Then treat them for 2 months. Because some reduction is probably better than none. CoQ10 supplements, they don't work. In our studies, they do not work. And finally, vitamin D. Vitamin D probably is associated. People with low vitamin Ds probably get more symptoms. And then in the United States, we can use PCSK9 inhibitors. I'm going to stop because I've got a few more slides, but I don't want to do them because I don't want to keep you long. And at least for me, this would be after work. I'm not big into after work. So I'm going to stop. Thank you very much for the opportunity to speak to you. I hope it was useful. I hope my English was acceptable to you.
In terms of hard endpoints, the benefit of statins is very different in primary prevention and secondary prevention.
Say it again. In terms of endpoints.
Hard endpoints.
Yes.
In control trials.
Yes.
The benefit of statins is very different in primary prevention and secondary prevention. So my question is, if you are not afraid of being very generous in the prescription of statins in primary prevention.
No, I'm not afraid of the prescription, but I don't think everybody should get them. I think you need to decide who should be treated. Some people with very low levels and very good family histories. So if someone comes to me and they're worried, right, and their cholesterol levels are very low, if they're worried because of a bad family history, I will usually measure lipoprotein A, because lipoprotein A is genetic, and it can take good cholesterol levels and make them act badly. So, you know, a lot of people think everybody should be treated with statins. I'm just not there yet because I see a lot of people with muscle troubles. And so I'm just concerned about doing everybody. But you can make that argument. Make that argument. A lot of people think you should. What else?
It's very common that you have patients practice exports, for instance, tennis or whatever, or they run.
Yes.
And when you put them therapy or statins, they complain about the fatigue and symptoms or pain when
Yes.
they run, and they don't tolerate so much. what would you do in these cases?
So first of all, there's some evidence that I didn't go into that statins may block some of the exercise training effects. For example, there's a study out of the University of Missouri where they took people on a simvastatin or placebo, and the people that got the simvastatin did not increase their oxygen uptake, did not increase their mitochondria number after 12 weeks of training. A lot of my patients complain as well. So if they need the drug, what I try to do is low-dose statins in combination with ezetimibe. We've taken a lot of athletes and we've measured muscle strength. And even though they complain that they're weaker, it's very hard to show it. In our studies, they complain they're weaker, but when we actually measure them on a dynamometer, leg extreme, they're not weaker. And we had a big grant from the government to study strength with 80 milligrams of atorvastatin. We showed more pain, but we could not show more weakness. So you've got to listen to the patients, because if you tell them, they'll stop. So what I try to do is I never ignore their complaint. I say, this is important for you, let's try ezetimibe in combination with low-dose rosuvastatin. We do a lot of 2.5 of rosuvastatin, the 5 milligram pill cut in half, Monday and Thursday. And with ezetimibe, you can get almost a 40% reduction and very few complaints. But it's a hard group. We know what they should do, right? But if you ever try to, at least in the United States, if I ever try to tell them what to do, they either don't do it or they find a better looking doctor. How is that possible? I know, but they do.
In the United States, the medical doctors follow strictly the guidelines because, all the studies says 80 milligrams or atorvastatin or 40 or simvastatin,
Yes.
and so on. And at least for us in Argentina, it's absolutely difficult and in some cases impossible to reach such level of milligrams because the people don't tolerate. I don't know what's happening in the United States.
Well, I always said, I looked at one point how many guideline committees I had been on. And I had been on a lot of guideline committees. And the last time I checked, I put my pantalones on one leg at a time. So these guidelines are just made by people like you and I, right? I don't think guidelines are perfect. I actually think that those 2013 guidelines are not good, because I don't want everybody on 80 and 40 of atorvastatin. I think it's too much. So I disagree with them, and the patients complain when they're on those high doses. So I know what the guidelines say. Most doctors in the United States do not necessarily follow them, because there's been a lot of anger about them, because they're too aggressive, we think. So I came all the way from the United States for 3 preguntas. That's a joke.
You have a patient with metabolic syndrome, with mild triglycerin, diabetes, hypertension, LDL. What's your goal? How do you start treatment?
So if I have a patient with metabolic syndrome, what's my goal? So my goal...
What's my priority?
Yes, what's my priority? So on all of those people, I try to start them on an exercise program. It's a very interesting thing. If you exercise hard today, your triglycerides are low tomorrow morning. If you exercise hard in the morning, your blood pressure is lower for the next 12 hours. If you exercise hard this morning, your insulin sensitivity is a little bit better tomorrow. There's a study from the 1960s where they had a bunch of men whose triglycerides were 6 millimole. They had them run 3 miles. The next day their triglycerides were 5 millimoles. They had them run 3 miles. The next day they were 4.5. They had them run 3 miles. They were 3. It went down day after day. So weight loss, exercise, but I put those people on a statin and I try to get their LDL to 70 milligrams per deciliter or just under 2 millimole. But, you know, the metabolic syndrome and weight loss, the metabolic syndrome, exercise and weight loss is one area where we can make a big difference if people will exercise. Now, it's very difficult in the United States to get anybody to exercise. And, you know, I understand that. Because, you know, people have jobs and children and bills. And, you know, so I don't want to be critical. But I do try to get them to walk and exercise if possible. Now, some of those people, I left this out. I do a lot of oral glucose tolerance tests. You know, when we talk about pre-diabetes, that's a bad idea. Because most people with pre-diabetes have already lost a lot of their beta cell function. Some people say that with pre-diabetes, right, you've lost 80% of your beta cell function already. And if you live a long time, because we take good care of you, you'll wind up diabetic. So I'm very big on doing oral glucose tolerance tests, and if it's abnormal, starting those people on things like metformin, etc. I think of metformin as exercise in a bottle, because, you know, metformin increases the number of mitochondria, etc. And at least in the United States, diabetes is becoming a cardiovascular disease. More and more cardiologists are starting to take care of diabetes. We have too few endocrinologists, and and they wind up in the cardiologist's office ultimately.
The last question. Do you think that the PCSK9 inhibitors in the near future will replace statins?
Do I think they'll replace statins? No, because of the cost. The PCSK9 inhibitors are very costly, and the price will come down somewhat, but they're still very difficult to manufacture because it's biomedical engineering. And I've been to some of the factories. They're gigantic factories where they're growing hamster ovary cells to make it and purifying it. No, I think they will be expensive, and the cost will keep them away from most people. Now, the medicines company has a PCSK9 inhibitor that interferes with messenger RNA. You can give it once, and it lasts 270 days. So even if it's expensive, you know, for that one injection, it may turn out to be cost efficient. So the ones we have now, too expensive. The ones coming, maybe.
Thank you very much.
No, thank you.